So starting with anatomy, the first anatomical thing we'll talk about are the regions of the small intestine. There are three main regions of the small intestine. The first is the duodenum, highlighted in light blue. This is an important area for the beginning of nutrient absorption and macromolecule breakdown. This is also an important region when it comes to iron absorption. The jejunum is where your macromolecules continue to be absorbed in your intestines. And sometimes on tests, they like to note that that folate is preferentially absorbed in the jejunum. And the last of the three small intestine regions is your ileum. And again, you're going to have more absorption in this region. And they really like you to know that vitamin B12 is absorbed in the ileum, specifically the terminal ileum of the small intestine. So we'll start by talking about the duodenum. As we just mentioned, it's the most proximal portion of the small intestine. And they do like to test its anatomic relationship with a few other associated organs, which we'll go over in a little bit. I want to highlight that it is very important for iron absorption, and you'll see that some pathologies like celiac disease, which can damage your duodenal epithelium, you might present with iron deficiency anemia as one of your symptoms because of that association. The duodenum has four primary parts. You have the first part, or the superior part, the second part, or descending. Your third part is your horizontal part, and your fourth part of the duodenum is called your ascending part. So I'll quickly go over these four sections. The first portion of the duodenum is located right here. It's the only intraperitoneal segment of the duodenum, and it's referred to as the duodenal bulb. You can see it kind of looks like a light bulb. This is the site, if you ever have a duodenal ulcer, you're going to see the ulcers in this region. If you ever see ulcers past this region, you really should consider Zollinger-Ellison syndrome, because all of that gastric acid should have been neutralized by bicarb, and ulcers should not be forming past this region. And one important landmark to realize is that the liver and duodenum connect at this region via the hepatoduodenal ligament. And I do want to spend some time talking about this ligament because it contains an important structure. So on this screen here, you can see the duodenal bulb, and it's attaching, there's a landmark right here. There's three vessels that are attaching from our duodenal bulb here to the liver, and that's attaching via this hepatoduodenal ligament. And so this is part of the anterior border of the lesser omentum. The lesser omentum is this region. I'm just pointing out some of the anterior region of it. It also goes deeper. And what's important about this hepatoduodenal ligament is that it contains our portal triad. The portal triad is made of the common bile duct, the proper hepatic artery, and the portal vein. And one important clinical consideration is that we can actually do something called a Pringle maneuver, which is where we clamp down on this ligament, which would also clamp down on the portal triad, and it can give us an idea of where a bleed might be coming from. So let me just talk about this really quickly. We have the Pringle maneuver. You can see here that the hepatoduodenal ligament and the portal triad are clamped. And so we would use this if we see something bleeding, or especially around the liver, but we don't know exactly what's causing the bleed, okay? And again, this is clamping blood flow to the portal triad, which are these three vessels we just talked about. I talk about hepatic blood supply in greater detail in the liver lecture, but it's pretty straightforward to understand. All of our GI tract organs drain blood into the portal system, and that goes through the portal veins, which drain into the liver, and from there it goes to the hepatic vein, and then into the IVC, which is our main vein that drains blood back to our heart. The liver also receives a second blood supply from our hepatic artery. So in total, there are two blood sources that supply blood to the liver, and I've highlighted them here. But keep in mind that if there is a bleed in this region, it could also be bleeding from the hepatic vein or the IVC, because they're all really close anatomically. So how do you determine what is actually bleeding? You can actually clamp down on the portal triad, which recall the portal triad has the common bile duct, proper hepatic artery and the portal vein. So if you clamp down on these two and bleeding stops, well, actually, let's start with if bleeding continues. Okay, so if you've clamped down on this artery and you still notice bleeding, then you know that it's more likely that the hepatic vein or the IVC are the bleeding vessels. On the other hand, if the bleeding does stop after you've clamped the portal triad, you have a better idea that it might be the portal vein or hepatic artery that's actually causing the bleed. And then to differentiate these, especially on tests, they will tell you that if there's a pulsating, bounding bleed that stops, that sounds more like an artery, so they want you to pick the hepatic artery. Whereas if they tell you there is some oozing bleed that stops with the Pringle maneuver, they're leaning more toward a portal vein bleed. The second part of the duodenum receives drainage through multiple structures. The common bile duct right here, and the main and accessory pancreatic ducts. I've only drawn the main pancreatic duct on this image. And a condition you should think about is annular pancreas that occurs in the second part. You can see here, we talk about annular pancreas in the pancreas section, but I just want to point out that it is constricting that second part of the duodenum, and it can cause obstruction. The third part of the duodenum is the horizontal part. And anatomically, the important thing to realize is that this region of the duodenum actually goes in between our aorta and our SMA. You can see this right here highlighted in the red circle. And this is important because there's a condition called SMA syndrome that can actually squeeze down on this duodenum if there's not enough fat cushion surrounding the duodenum. So here's a good picture kind of highlighting this. We see our duodenum and between our SMA and our aorta in both of these pictures. And what's going to happen in SMA syndrome is that our third portion of duodenum is going to be starting to get squeezed because there's less mesenteric fat. You can see on the left how there's plenty of fat that cushions the duodenum and keeps the lumen open, whereas on the right, that fat has been lost, and now the SMA is able to push against the duodenum and actually constrict the lumen. And so there's two conditions that you should think about that could cause this, and both of them involve a rapid loss of, or a loss of this fat cushion. So the first I want you to think about is somebody with significant recent weight loss. So if a lot of your fat is mobilized, you might be losing that mesenteric fat that protects your duodenum. And then anybody who's malnourished likely doesn't have fat stores in the first place, so they could also suffer from from SMA syndrome. And the only symptom that you really need to know is that it could cause postprandial pain, which makes sense as you eat, you're going to have more a bolus of food pushing against this. And if you're pushing against this obstructed lumen, you can easily cause distension and inflammation. The fourth part of the duodenum is the ascending portion, and this connects to the jejunum at what's known as the duodenal jejunal flexure. That's not as important, but what is important is to know that this ligament of Treitz that connects to the duodenal jejunal flexure is a common landmark used to differentiate between upper and lower GI bleeds. So if a bleed occurs proximal to the ligament of Treitz, it's considered an upper GI bleed, and distal to this would be considered a lower GI bleed. Now we can move on to the other two regions of the small intestine. Both the jejunum and ileum are built for mass absorption. The jejunum is known for folate absorption, as we talked about earlier, and the ileum, with a specific attention to the terminal ileum, is known for vitamin B12 absorption. Let's talk now about the blood supply to the duodenum. The duodenum receives blood supply from two of our three primary GI arteries. So our proximal duodenum is part of our foregut, which should give you an idea that the celiac artery is the artery that supplies it, whereas our distal duodenum is part of our midgut, which would be supplied by our superior mesenteric artery. So let's go through how the proximal duodenum is actually supplied. We'll start with our celiac artery right here. The blood will flow from the celiac trunk through the common hepatic artery, then the gastroduodenal artery, and finally the superior pancreatico-duodenal artery to supply our proximal duodenum. And I can show that in another picture here. We have our celiac trunk, common hepatic, gastroduodenal, superior pancreatico-duodenal. So that's how the proximal duodenum is receives its blood supply. And how about the distal? So the distal is a lot more straightforward. You have your superior mesenteric artery right here, and a branch of the SMA is the inferior pancreatico-duodenal artery. Now, clinically, the only thing important to realize is that the superior and inferior pancreatico-duodenal arteries do have an anastomosis, so they can connect like this. And like we saw in the stomach lecture, if you have collateral circulation, you have a decreased risk of ischemia. For example, if we have some sort of blockage in this region, we can often supply blood from the collateral circulation, from the SMA in this case, and the opposite would be true as well. Blood supply to the jejunum and ileum is very straightforward. They all receive branches off of the SMA. There's nothing you really need to know as far as any anastomoses, watershed areas, or collateral circulation. All you really need to know is that the SMA in general branches off at less of an angle than the celiac artery, which makes it more prone to something called acute mesenteric ischemia, which we talk about later. I'll show the diagram that I use in acute mesenteric ischemia to show you what I mean. Oftentimes, acute mesenteric ischemia, excuse me, is caused by an embolic occlusion. So you have a clot that originates somewhere else and it travels down and then it gets stuck in the SMA. And so if we have a clot in our heart, for example, that can branch off and start moving through our systemic circulation. And the first major GI organ that it might lodge in would be the celiac trunk. But because the celiac trunk is at more of an exaggerated angle to the aorta, oftentimes the clot will actually pass the celiac trunk and it'll only get lodged in the next GI artery, which is our SMA, which is less acute of an angle. So it can get stuck in that region. Let's talk now about the cell types of the small intestine. First, we can talk about G cells, which we also discussed in the stomach lecture. They produce gastrin. S cells produce secretin. I cells produce cholecystokinin. K cells produce a hormone called GIP. And then motilin produces they help facilitate something called migratory motor complexes, or MMCs. So we're going to go over each of these 5 now, starting with G cells. Hopefully this will be a little bit of a review. And these are located in our pyloric antrum and duodenum. They're located in the lower glandular layer in our stomach. So this is from our stomach lecture. The lower glandular layer is located here. We have chief cells, G cells, and D cells in this area. Remember, the upper glandular cell is where parietal cells are located. And then our surface epithelium is where our mucus cells are located, just as a reminder. And the function of these cells are just to secrete gastrin. And a good mnemonic of our G cells, there are gas cells because they provide the gas for the stomach. They increase the amount of hydrogen ion secretion, they increase gastric motility, and gastric mucosa growth. And as a reminder, a good way to remember that they increase the hydrogen ion secretion other than the mnemonic, I just want to bring you back to, again, from the stomach lecture, this mechanism by which hydrogen ions are getting secreted out into the gastric lumen is the gastric lumen is often facilitated by gastrin. And again, this is how it's regulated. So because it produces so much acid, you obviously would want it to be decreased in acidic environment and increased in basic environments as a homeostatic regulator. And so when we eat food, our stomach in general becomes more basic, and so then you can release more acid in those situations, which has physiologic benefit. You can also get more increased release if you have vagal stimulation. If you start using antacids, you're going to obviously increase the pH. And then we talked about this a lot in the stomach lecture. If you have chronic gastritis and you have a lack of parietal cells producing those hydrogen ions, you're also going to get gastrin upregulation and G cell hyperplasia. And pathologies we have to know about is Zollinger-Ellison syndrome, which is a gastrinoma. I talk about that in the stomach, and pancreas lectures as well. So let's move on to a new cell we haven't discussed yet. This is the S cells. So S cells produce something called secretin. They're all located in the duodenum. So I'll draw one here. And let's talk about what secretin does. It's really important. We have all this acid that's coming from the stomach into the duodenum. So our S cells are really good about producing bicarb to neutralize all that acid. So secretin acts on the pancreas and produces bicarb, and this will help neutralize a lot of the gastric acid. And another thing to even help out more with this, to turn the tides in favor of a more basic environment, is secretin can also decrease gastric acid directly. So secretin can come in and turn off some of the gastric acid. The last thing it can do is it can increase our sphincter of Oddi relaxation, which we haven't talked too much about the sphincter of Oddi, but the sphincter of Oddi, if it's open, then more materials can flow in from the pancreas and the gallbladder into the duodenum, so it can facilitate enzymatic breakdown of nutrients. Our next cell we're going to talk about are eye cells, and they produce an important hormone called cholecystokinin. So these are located in the duodenum and jejunum, and what happens with eye cells is that they get stimulated by the presence of fatty acids or amino acids. So let's imagine we have fat or a fatty acid in our duodenum. These will trigger eye cells to release this cholecystokinin. And once cholecystokinin is released, it can stimulate gallbladder contraction. That's its main function. And that'll help facilitate the excretion of bile into the duodenum, which can break down fats. It can also increase pancreatic secretions, which again is physiologically important because the pancreas has a lot of lipases and amylases to help break down fats and sugars. And this will also relax the sphincter of Oddi, which, like we saw with S cells, if you have a relaxed sphincter of Oddi, you can get increased secretion into the duodenal lumen. The last thing it'll do is it'll actually decrease gastric emptying, because if there's too much fatty acids or amino acids in the duodenum, you kind of want to slow down the process and make sure you absorb everything that's already in the duodenum before you add too much to overwhelm the system. The next cell we'll talk about are K cells, and they produce something called GIP. And again, these are located in the duodenum and jejunum, and these are triggered by glucose specifically. I like to think of the K as candy cells. So once K cells encounter glucose, they'll release GIP. And what GIP does, first off, it has two names: glucose-dependent insulinotropic peptide or gastric inhibitory peptide. And it has two names, which reminds me it has two functions. So the first function we can talk about is that it decreases gastric ion secretion, which kind of goes with that second name, gastric inhibitory peptide. So it'll decrease hydrogen ion secretion. And the second thing it does, which is the more important of the two and the more testable of the two, is that GIP can stimulate insulin production. So GIP can act on the pancreas and increase insulin. And they like you to know this mechanism because you'll actually have higher levels of insulin in your body if you consume glucose orally. Because if you just get an IV injection of glucose, you're not going to stimulate your K cells in your duodenum or jejunum and release more insulin. So this is sometimes tested about why an oral load of glucose would cause a greater increase in insulin than an IV load. The last cell I just want to mention are motilin. Motilin's actually a hormone, but I do want to talk about it here. So motilin is a hormone that's produced, and it regulates something called migratory motor complexes, which I'll refer to as MMCs. And this helps us to provide peristalsis during the fasting state. So if you've ever heard your stomach grumbling when you're really hungry, that's an MMC in action. And these are actually turned off, not necessarily turned off, but there's a system that overrides it. When you eat food, you have a different system that facilitates peristalsis, but MMCs are important for continuing peristalsis even when we're not eating. And A drug that we sometimes use, erythromycin, which is also a macrolide, that is a motilin receptor agonist. So if motilin helps peristaltic contractions, it shouldn't come as no surprise that this medication can trigger intestinal peristalsis to treat some conditions like gastroparesis. The last anatomical subsection I want to discuss is small intestine histology. Here's a review that you might be sick of by now if you've watched some of the other lectures, but we have a lumen, a mucosa, a submucosa, we have our muscular layer, and finally the serosa or adventitia. And beyond that, you have your visceral peritoneum, your muscle, fat, skin, all that stuff. And just remember that the mucosa can be subdivided into the surface epithelium, the lamina propria, and then our muscularis mucosa. Remember that our submucosa is important for Meissner's plexus, and Meissner's with the S's, remember submucosal, Meissner's secretions. Our muscular layer has two different layers. We have a circular layer and a longitudinal muscle layer. And in between those is our myenteric plexus, which helps with peristalsis and sphincter tone. And then just remember that the serosa and adventitia are named based on whether they're intra or retroperitoneal. So now let's talk about what's going on with the small intestine. Here we have our lumen. You can see our mucosa is taking up the bulk of this picture. We have a little bit of submucosa toward the bottom, and we're not going to be able to see the other two layers in this image. So let's talk about each of the three mucosal layers that we can see. You can see our surface epithelium. I've highlighted a few of those regions right here. You can also see the lamina propria, which is kind of that connective tissue layer. And our muscular layer, the muscularis mucosa, is located at the bottom. So let's talk about what goes on at each of these layers in the small intestine and what you need to know on a histology slide. So the surface epithelium is made of our simple columnar epithelium with goblet cells. These are the same type of goblet cells and surface epithelium that we talked about in the lower esophagus and stomach lecture. Goblet cells are mucus-producing cells, and I circled a few to the left there. And they help, the whole surface epithelium provides a lining to the villi. If you see these finger-like projections that are sticking out, I think we can see like 5 or 6 fingers. Those are all referred to as villi, and they help enhance absorption. You can also see microvilli on the surface of these columnar cells. You can't really see it that well in this picture, but all this fuzzy area right here, this is all microvilli that are jutting out. And this whole finger-like thing is referred to as the villus. So crypts of Lieberkühn are also part of our surface epithelium, and they are invaginations of the epithelium between each villi. So you can see one crypt of Lieberkühn highlighted in red there. They have many important cells that are housed there. They have stem cells, which can differentiate into a number of our different small intestine cell types. So they have goblet cells, which we just talked about, are mucus-producing cells. They can produce something called Paneth cells, and Paneth cells are important for microbial defenses, because you can imagine when you're eating food, there's still a lot of microbes that can make it to your small intestine. And so my mnemonic for remembering that Paneth cells are important in defense, I remember that Paneths banneth invaders. Here's a picture of you can see Paneth cells here. They secrete many antimicrobial compounds, and the granules stain eosinophilic. So you can see these eosinophilic granules, these pink granules located right here. And again, the mnemonic, Paneth cells banneth invaders. Another stem cell product that's within the crypts of Lieberkühn are our enteroendocrine cells. And what kind of cells are those? Well, endocrine means hormones, so it should come as no surprise that some of the cells we just talked about are G cells that produce gastrin, our I cells that produce cholecystokinin, and our K cells, our candy cells that produce GIP. Those all can be housed in these crypts of Lieberkühn. There's another cell that I just want to mention. I've seen it on some resources. I've never seen this tested, but tuft cells also live here, and they have some non-specific immune regulatory functions. So we've talked about the surface epithelium. Let's talk about that connective tissue layer that holds up each of these villi. So our lamina propria provides a core for each villus, and I'll draw what the lamina propria encompasses. All of this region, other than this muscularis mucosa, is our lamina propria. And what's important is that the lamina propria provides this core of an artery or an arteriole, a venule, and a lymphatic channel. So this all runs through the lamina propria to provide blood flow to our surface epithelium. There are three specialized structures you should know that exist throughout the small intestine in specific parts. We'll start with the Brunner's glands. So the Brunner's glands are located in the submucosa of the duodenum. I know I didn't show a really good picture of the submucosa last time, but here you can see we have our lumen, you can see some villi here. This is all of our mucosa, and here you can see our muscularis mucosa, which is the deepest layer of our mucosal layer, and below that we have our submucosa. And so here are some Brunner's glands located in the submucosa of the duodenum, and their function is to secrete alkaline media to, again, counteract acidic chyme from the stomach. And so when I think of Brunner's glands, I think of the B in Brunner's for the B in base, to remember that Brunner's glands produce a basic media. Plica circularis are important for a different reason. They're located in the distal duodenum and jejunum, and the plica circularis can actually be visible through the naked eye. These folds of the membrane that you're going to see in a second can actually be seen not just under the microscope, but from the naked eye, excuse me. The function of these is to increase absorptive surface area, which is especially important in a region like the small intestine. So if we have our lumen here, we have a villi, and remember our villi, surrounding our villi are microvilli to, again, enhance absorption. So if you would imagine, this is an example of a section of the small intestine that, sure, you get a lot of absorption, but as you can see here, the mucosa itself is not folded in, it's just linear. So you're limited a little bit about how much absorption you can actually receive. Now, if we break that down and we show you that same image of a section of the small intestine without plica circularis, now imagine if we can fold the mucosa directly, then we can have a lot more villi and microvilli in this limited section and a lot more absorptive capacity. The last specialized structure I want to talk about are Peyer's patches. These are located in the terminal ileum. They're located throughout, but mostly in the terminal ileum. And their function is they house lymphoid follicles, which are our lymph nodes in our digestive tract. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.